This paper, it clearly mentions that the global varus malalignment it changes from the double leg to single leg stance phase due to intra-articular changes, and they have concluded that the varus malalignment along with JLCA increases with weight-bearing loading, and thus single leg stance radiograph they has to be considered for appropriate preoperative planning, considering the patient-specific changes in JLCA. His effort open review based on the treatment options available for medial compartment OA, it clearly states that if you just consider low revision rate as a key indicator for success to total knee replacement, it still remains the most successful option for treating medial compartment OA with a revision rate of 4 to 5% at 14 years. Another options which are available to us are unicompartmental replacement and the HTO. Both are effective treatment options in their own sense, and it has to be noted that the surgeon should avoid such options if they cannot expect to perform them in adequate numbers, and local referral pathways have to be considered. So talking about the medial pivot knee, this study which mentions about the clinical radiographic outcomes and survivorship of the design of medial pivot, it clearly mentions that the medial pivot knee they have excellent survivorship and low revision rate with excellent outcomes in terms of objective as well as patient reported clinical outcomes. There's another systematic review which talks about the midterm survivorship of medial stabilized knee. It also states that the medial pivot system is associated with better high-end function compared to standard implants. This GBGS article was recognized as the paper of the month for October 2021. They basically compared robotic arm assisted bicompartmental UK with conventionally mechanically aligned total knee, and they've compared their outcomes for the first 6 weeks and at 1 year post-operative period. So they mentioned that the robotic arm assisted cruciate sparing bicompartmental UKA, it offers clinical outcomes and the rate of complications are almost comparable to the mechanically aligned TK at 1 year follow-up. So is there any proof of concept for that? It's a systematic review which mentions that simultaneous as well as stage bicompartmental UK, they have good outcomes, and it indicates that bicompartmental UK is a viable surgical option for patients with bicompartmental femorotibial OA if the patient selection is appropriate. Right now, the volume and level of evidence is low, so we still have to wait. Unicompartmental knee replacement is definitely surgery of choice for classical anteromedial OA in appropriately selected patients. The original Cozen and Scott criteria which were mentioned, and in 2022 there are extended indications which we all know. I'll just highlight about the literature supporting this controversy. So when we talk about the obesity, this paper from Journal of Arthroplasty, it clearly mentions that the early major revision rate in morbidly obese patients was 5 times higher as compared to the normal patients. And contrary to this article in Arthroplasty today, it's a retrospective review of almost like 2000 unicompartmental knees performed, and it clearly says that obesity is not a contraindication for UK despite previous recommendations to the contrary. So this is a systematic review and meta-analysis, and this is also a meta-analysis which clearly states that there is no significant difference in the outcome between obese and non-obese patients, and currently there is no evidence that obesity has to be considered as a contraindication. So unicompartmental knee replacement in ACL deficient knee, this article from the Oxford group, it clearly mentions that ACL reconstruction with UK it is a preferable option for patients with ACL deficiency and bone-on-bone medial osteoarthritis in young and active persons. But in elderly and isolated UK with ACL without ACL reconstruction, it's a reasonable option and attractive if careful patient selection is performed. Absence of clinical preoperative instability is an important prognostic factor. Another article which mentions about satisfactory outcomes following combined unicompartmental knee replacement with ACL reconstruction, and this also says that for a appropriately selected patient, it is a valid treatment option. Evidence of patellofemoral arthritis, whether UK should be performed or not. So Berend et al. Has found that there was no statistical difference in the survivorship of UK and performed in patients with and without PFA. Hamilton and Pandit et al. They considered that neither the clinical radiological state of the patellofemoral joint nor the presence of anterior knee pain is a contraindication for unicompartmental knee replacement, except for bone loss and grooving to the lateral side. Thai et al. They have found that unicompartmental knee replacement centralizes the patella congruence angle without impacting the patella height. When they propose that restoration of patellofemoral congruous angle, it releases the load from patellofemoral joint and mitigate the symptoms which are related to patellofemoral degeneration. Therefore, patellofemoral joint osteoarthritis is not anymore a contraindication for medial UK if the patient is asymptomatic. Now, talking about conventional versus robotic, So this systematic review meta-analysis, it states that the robotic-assisted UK, they have fewer complications and they have low revision rates compared to conventional UK. But definitely there are limitations and lack of reliability, and more studies are required for this. So another study from Journal of Experimental Orthopedics, they say that robotic-assisted UK are associated with better rate of joint line restoration due to less femoral component distalization compared to conventional UKA. There's another meta-analysis which also states that the robotic-assisted UK and TKA, they resulted in non-significantly better range of movements and lower rate of revisions and associated with increased surgical time. Comparing fixed bearing versus mobile bearing UKA, it clearly mentions that there is no difference in the clinical radiological outcome on long-term follow-up, but definitely there is differences in the modes and timing of failure. The bearing dislocation leads to early failure in mobile bearing processes, whereas polywear, it leads to later failure in fixed bearing processes. Talking about meniscal substitution, like scaffold transplantation as well as substitution. So this paper from the Journal of Experimental Orthopedics, it clearly mentions about autologous allogenic and artificial meniscal substitutes. So they have mentioned the indications and contraindications for meniscal substitution as well as meniscal allograft transplantation. So in this schematic representation, you can clearly see there is a meniscal substitution being performed for a partial meniscectomy, and the collagen meniscal implant as well as Actifit is available for meniscal substitution on a scaffold-based model. And this goat model, which represents that the mesenchymal stem cells, they are harvested from the infrapatellar fat pad, and this is a goat meniscus, which you have seen. They have introduced an iatrogenic meniscal tear, and it has been categorized into three category. The meniscus which was untreated, meniscus which has undergone a repair, and meniscus which has undergone repair along with augmentation. And clearly you can see that the neo tissue formation and the gap minimization is good in augmented meniscal repairs. Thank you.